So welcome back, everyone. We're here for Dr. Hale's presentation. And first, let me just introduce Dr. Hale and his bio so you know a little bit of his background. Daniel E. Hale, MD, is the Chief of Pediatric Endocrinology and Diabetes in the Department of Pediatrics at Penn State Hershey Children's Hospital. For the previous 22 years, he held the same position at the University of Texas Health Science Center at San Antonio. He currently serves as the medical director for the Chromosome 18 Clinical Research Center. So thank you so much, Dr. Hale, for joining us this morning for the research update, and then joining us again this afternoon, or I guess evening on the East Coast for your presentation.
Kind of depends on where you are. Yeah. So I think everybody knows I'm in Hershey, was in San Antonio for many, many years and know all the players. So I will speed through this. I am purposefully not going to read every slide, but I assume the slides will be available for people's review. So if we can go ahead and get started. So I think probably the most common question that I've been asked as a clinician for the last 35 years is, why doesn't my pediatrician know anything about chromosome 18 disorders? And I think it's really helpful for people who don't work in medicine to understand that the reason why they don't know anything about chromosome 18 disorders is because literally they've never seen an affected individual. Most pediatricians have a practice of somewhere between 2,000 and 5,000 patients. And so maybe they have a friend or somebody or a patient that had a trisomy 18 pregnancy, but the chances are only 1 in 10 to 1 in 100 that they've ever actually seen a child with one of the other defects. I would also say, as a parent or family, you really have to make an effort to bring the pediatrician in or the family doctor in as part of your child's team. A number of years ago, we put together the treatment guides, and I would make a point, if I'm seeing a new provider, to print out the treatment guide as opposed to referring them to the website, give them access or let them know where they can also find these online, suggest keeping a notebook of medical records and pertinent tests. When you're in to see a specialist, especially, stay on topic. The cardiologist really is not going to help you with your child's constipation. And also, all of us get evaluated by our patients. If you have nice things to say, please say them. People notice that, and that keeps you on their attention. And lastly, my mother was a fabulous baker, and whenever she went to the family practitioner's office, she always took cookies, and she could always get in and talk to somebody in about 5 minutes, which was kind of a nice thing because they liked her cookies. So don't forget the human element. Next slide. So what we want to do is to really summarize a little bit of clinical endocrinology, to describe a few signs and symptoms and some common tests, to provide guidance on how to find some more information, to delineate some of the remaining issues, and then try to answer some of the frequently asked questions, and then give time for some questions from the audience. So some terminology that's here that just tells you about what are the key organs when it comes to the endocrine system. And this is something that one can easily Google each one of these individually to get more information. The major focus of much of what we do is on the pituitary, largely because a relatively high percentage of the children with almost all the disorders have growth hormone deficiency or insufficiency, and that is produced directly by the pituitary. But don't lose sight of the fact that the pituitary produces a number of other important hormones for other functions. Next. So just a reminder, pituitary sits right smack dab in the middle of your head. It gets all of its signals from the higher centers of the brain. So when you hear us talking about hypomyelination or undermyelination in some of the conditions, myelination is like the insulation on an electric cord. And if the myelination is not there, doesn't work normally, then signals don't go where signals should go. So this is just a picture of the anatomy to show you where it's located. We're going to talk through some of the individual defects. Next slide. So, and here's a little bit more graphic picture. There we go. So, oops, back one. There you go. There. The joys of, yeah. So again, just a picture of what we just talked about. You can move ahead to the next slide. So when we talk about primary dysfunction, we mean that an endocrine organ doesn't function normally. So for example, if your thyroid has been removed, then you have primary hypothyroidism. On the other hand, if the pituitary factor that regulates your thyroid gland is not functional, then we refer to that as secondary hypothyroidism. Or if there's a problem with the higher centers of the brain above the pituitary, we use the word tertiary. We all get rather sloppy with this terminology, but when it comes to growth hormone deficiency, most of the children have primary growth hormone deficiency, i.e. the pituitary does not work appropriately. Next slide. We also like to talk about a variety of things. Isolated pituitary deficiency means there's only one hormone missing. Multiple means multiple. And we often get sloppy. We often use the word pan-hypopituitarism, which means that three or more are missing. And then lastly, a phrase that has come up occasionally and causes some confusion is something called diabetes insipidus. And this is not sugar diabetes, which is relatively common, but rather this is where the body doesn't make a hormone that helps you concentrate your urine when oral intake is decreased. And that typically presents with recurrent episodes of dehydration. I would also mention this only in passing, that for hormones to work, they have to come up and attach to the surface of the cell and tell certain things to occur inside of the cell. So if you think of a hormone as a key, the way that the hormone attaches to the cell is called a receptor. And the problem is in some patients with some hormonal issues, they make the hormone just fine. They simply are missing the receptor. And in passing, to note that so far we have not identified any forms of a hormone resistance, i.e., the major problem is that the children and adults don't make some of the hormones, but if the hormones are made, then they are able to instruct the cell appropriately to do the things that a particular cell needs to do. So we're going to go through the systems now one by one. So this is basic terminology. If you're in to see the endocrinologist for your child or for yourself, this is sort of the typical phraseology that you will hear. So hypothyroidism means that your thyroid is underactive, or if you're on medication, you're not adequately treated. Hyperthyroidism is that your thyroid is either overactive, or if you're on medication, you're overtreated. And euthyroid means normal function or that you're on adequate treatment. We also use terms for structure. So if we say that somebody has a goiter, it just simply means the thyroid is big all over. In contrast, if we say that somebody has a nodule, it just simply means they have a lump or a bump on the thyroid, much like if I say you have a pimple on your face, your whole face is not enlarged, but just a local area is enlarged. Next. The thyroid gland primarily produces thyroid hormone, but the production of thyroid hormone is very much controlled by the pituitary. The hormone that's produced by the pituitary is called thyroid stimulating hormone. And so if you have an underactive thyroid, then the pituitary attempts to make it work harder. So the TSH is going to go up. In contrast, if somebody has an overactive thyroid, then the pituitary is going to try to tone it down by lowering the level of TSH. Next. By far and away, the most common cause of thyroid problems in all people of all ages and both genders is a condition which is most commonly called Hashimoto's thyroiditis. It's also sometimes called chronic lymphocytic thyroiditis or autoimmune thyroiditis. It also is quite common in almost all of the major chromosomal abnormalities, including Down syndrome and Turner syndrome. The individuals at diagnosis with Hashimoto's may be hypo, hyper, or euthyroid, and they may or may not have a goiter. There are specific bloodstream markers for this diagnosis that are readily available. When it comes to the chromosome 18 abnormalities, all of the children and adolescents seem to have an increased risk of developing Hashimoto's thyroiditis. The good news is very treatable. The medication has been around in clinical use for more than 200 years, and it's a one oral pill per day. There's actually now a liquid form for children that can't take pills. The other common thing that we see in pediatrics is Graves' disease. That is an overactive thyroid, may involve organs and tissues other than the thyroid. And again, there have been effective medications for the treatment of this condition for probably 75 years. We've seen a lot of Hashimoto's and all the chromosome abnormalities. We have occasionally seen Graves' disease, but it has been uncommon. Next. I just listed the signs and symptoms of hypo and hyperthyroidism here for you. I'm not going to read through these. They're there for your reference. And you can also search online. If you just look up hypothyroidism, you can find sort of classic symptoms and signs. Next slide. As I mentioned, thyroid disorders occur in 1 to 3% of the general population, more common with increasing ages. And the secondary forms, so problems where the pituitary doesn't work appropriately, are actually unusual. They're about 10 times more common in the major chromosomal abnormalities. They appear to have relatively early onset in children with chromosome 18 issues. And as I mentioned, the most common form is Hashimoto's thyroiditis. From a very practical consideration, the pediatricians are very accustomed to monitoring thyroid levels on an annual basis in children with Down syndrome. And I generally recommend that if children are having blood tests done, that thyroid levels be monitored on a yearly basis on kids with chromosome 18 abnormalities. And that's included in all of the management guidelines. I think, at least in the US and most of the westernized world, all children are screened for thyroid conditions in the newborn period. But we also, as I mentioned, recommend treatment screening annually for all the chromosome 18 abnormalities. And if the individual is hypo or hyperthyroid or has a goiter, then appropriate antibody screening can be done. Thyroid medication has been around for many, many years, safe and effective. The dosing is very standard. There's no indication that children with chromosome 18 abnormalities need a unique dose. The most common situation where we see secondary or tertiary forms of hypothyroidism really are, I don't know what an idle timer is. Is that me or you?
I'm not seeing anything that says idle timer. I
Oh,
wonder
okay.
if that's something on your computer, maybe?
Oh, maybe. Let me see.
Or did you have a timer on the present? No, you're not showing the slides.
No, I don't. I just suddenly it popped up. Can you see it?
I can't see that. No,
Oh, that's weird.
so strange.
Okay.
Everything
Well,
looks good on our end, though.
Maybe I can. All right. So the good news is thyroid medication has been around for a long time. The medication itself is identical to what the normal. Uh, this is weird. All right, let me try something here. Sorry, guys.
No problem. I wish we could help, but we don't see anything like that on our end.
Yeah, there's just a big blob right in the middle of my screen.
Does it look like a Zoom notice?
It just says idle timer expired. Session has been idle over its time limit. Let me try sharing my screen. How about?
Sure. And let me make you a co-host real quick. I don't think I did that yet. Okay.
Okay.
Okay, you're a co-host, so you should be able to share your screen.
Can you see that weird thing?
I do not see your screen yet.
Okay. All right. Huh. All right. I'm sorry, everybody. I think I'm going to get out and come back in. That's about the only way I know to fix this.
No problem. We can wait on hold. Oh, now I can see your screen, Dr. Hill.
Okay. Now you can see it. But can you see my weird idle timer?
I can. It almost looks like a PowerPoint
Up.
notice.
Now it
Oh,
went away.
okay.
Away we go. All right. So let me get to where I was. I'm so sorry.
No problem. I think you were on, Jessica, do you know what slide number you were on?
Yeah, here. Yeah, I know where I was. Yep. We were here. And let's see, there's some way of making it pop wider open here.
If you go to slideshows at the top.
Yep. Did that pop all the way open for you?
Not yet.
Okay.
But we can see it pretty well.
Okay, that's fine. Yeah, so the recommendations are here, which are newborn screening should be done. Kids with hypothyroidism should be screened on an annual basis. With children with chromosome 18 abnormalities should be screened on an annual basis. There is now a liquid form for children that have difficulty obtaining taking pills, which is kind of nice, in particular for younger children where some of the kids have G tubes in place. Adrenal. So adrenal insufficiency, commonly called Addison's disease. Probably the most famous person in the world that had Addison's disease was John F. Kennedy, former president of the United States. Adrenal steroid excess is called Cushing's disease. The adrenal primarily produces cortisol, which is the stress hormone, aldosterone, which is the hormone that helps your body hold on to salt, and androgens, which are the so-called male hormones that are responsible in ladies for things like pubic hair, body odor, those sorts of things. They're not terribly important in males. The adrenal is largely regulated by the pituitary gland. Most common reason for adrenal steroid excess is that steroids are used for a variety of medical conditions, such as severe asthma, rheumatoid arthritis, etc. And so that's the most common reason for adrenal steroid excess. The most common reason for adrenal steroid insufficiency is for people when they've been on long periods of treatment with steroids, their own adrenal atrophies over time. The classic symptoms are noted here. Again, I'm not going to read through these. We have seen a few children with adrenal insufficiency, but almost always they have been in the context of children that have other pituitary deficiencies, not that it's an isolated event. The one that we tend to see most commonly as an isolated entity is growth hormone deficiency. Adrenal insufficiency, not secondary to treatment or trauma, is relatively quite uncommon. 4 to 8 cases per million people, more common in women. There's rare genetic defects. We just have not seen much of this at all. Adrenal steroid excess is not due to medical treatment. Again, even more uncommon than adrenal insufficiency. As a side effect, if any of your children have been tested for growth hormone, as a routine part of that testing, cortisol is usually measured to confirm adrenal sufficiency. I think I've already mentioned this. We don't seem to have any evidence of increased or decreased adrenal issues in individuals with chromosome 18 abnormalities. No routine testing is recommended except in the context of a child that has multiple other pituitary deficits. I think I already made those points. I'm ahead of myself. Gonadotrophins. So gonadotrophins in males, of course, the gonad is a testis. In female, the gonad is the ovary. The word trophic or trophin simply means something that stimulates growth or function. There are two gonadotrophins, a luteinizing hormone, which stimulates ovulation in the female, stimulates testosterone production in the male, and FSH, which is responsible for the development of ovarian follicles and female and stimulates sperm production in males. Precocious puberty, by way of definition, is evidence of puberty before age 8 in females or age 9 in males. Delayed puberty is defined as no evidence of puberty by age 14 in females or age 15 in males. I've included definitions because these are things that any pediatric endocrinologist is going to use. In infants, deficiency of the gonadotrophins has been associated with genital abnormalities in the male, most specifically undescended testicles or an underdeveloped penis. No obvious findings in a female from this problem. In children and adolescents, abnormalities of the gonadotrophins have been associated with both precocious and delayed puberty. And in adults, abnormalities are associated with menstrual irregularity and fertility issues. So genital abnormalities in the typical male infant, about 1 in 200 infants. The most common thing is hypospadias, and that means that the opening out of the bladder is not on the tip of the penis, but somewhere along the shaft of the penis. Undescended testicles, about 3 in 100. So even more common, bilaterally undescended testicles, about 3 in 1,000. And all of these are higher in preterm infants. External abnormalities of genitalia in the female are quite unusual. Precocious puberty, generally quoted as being around 0.3 to 3%. It's about 1/10 as common in males. Pubertal delay is considerably more common in males. So what do we know about chromosome 18 abnormalities? Well, there is some variability depending on which defect we're talking about. About 50% of the boys with 18q have genital abnormalities, the most common one being hypospadias. There are case reports of precocious puberty in all of the chromosome 18 conditions, but the numbers are not sufficient to allow me to say whether it's more common or less common than in the general population. There are also case reports of delayed puberty in all of the chromosome 18 conditions. And actually, when we looked at the average age for the onset of menses in the 18q girls a few years ago, they in general were about 1 year later than their peers, but that's of no clinical significance. Menstrual irregularities are pretty common, but in all women, there's no data to suggest it's more common or less common in the girls with chromosome 18 abnormalities. We know that fertility is possible in females with some of the conditions, particularly the girls with 18q and 18p, and unknown in others, which is why we keep asking these questions. Fertility is unknown in males. We're aware of a few case reports of azoospermia. What that means is that no sperm is being produced. But if we look at virilization, so genital development, going through puberty at typical ages, most of the kids go through puberty just fine. It's more that they don't produce, or at least as far as we know, don't produce viable sperm, although that's not been looked at in any kind of systematic fashion.
Dr. Hale, I'm sorry to interrupt, but I just want to give a 5-minute warning. And we do have a 15-minute break after, so we can go into that a little bit with a question or two.
The approach here is that identical to a child who does not have a chromosome 18 abnormality, and there are adequate treatments for all of these conditions. Growth hormone, we talk about this every year at the conference. I've listed some terminology. The one point I like to make is if you have a quote unquote growth hormone test done and it's a single blood draw, almost assuredly they're measuring a growth factor, not growth hormone. The two growth factors that are the most common markers for growth hormone are IGF-1 and IGF-BP3, which are lined out here. But that is a screening test, not a definitive test. The definitive test is something called a growth hormone provocative test or a growth hormone stimulation test, and that requires 2 to 3 hours and multiple blood tests. So when the pediatrician said they've done the test for growth hormone, the answer is no, you have done the screening test for growth hormone. Some summary about linear growth, what one can see, but a critical factor, particularly for many of the kids in the early years of life because of hypotonia, don't gain weight well. And my general message is, in that regard, is if the child is not gaining weight consistently, particularly in the first couple of years of life, they are not going to they're not going to grow linearly. So really push on the calories to ensure that the weight is keeping pace with the child's age. There are growth rate charts, which your pediatrician or your pediatric endocrinologist should have access to easily online and in many of the electronic health records. So when you ask how fast should my child be growing, very dependent on the age of the child. Growth hormone deficiency is generally quoted as about 1 in 2,000 typical children. It is known to be more common in many of the chromosomal abnormalities. It may occur in the context of multiple pituitary disorders. It's also more common in children with midline defects such as cleft lip or cleft palate, things which are a bit more common in the kids with 18q. And obviously, it's going to be more common if something bad has happened to the head somewhere along the way. We know that all of the kids with chromosome 18 abnormalities, it's more common from about a half to 2/3 of the kids with 18q minus are growth hormone deficient. It's lower percentages for the other chromosome 18 conditions, but there needs to be a higher index of suspicion of this in all the chromosome 18 conditions, which means a pediatrician needs to be tracking linear growth. My response is always look at the child, not at the laboratory test. And the question is always, if my child did have a chromosome 18 abnormality, what would be your evaluation for his or her poor linear growth? And when you get the answer, then say, can we please proceed down that path? Growth hormone's been around in clinical use for more than 50 years. Biologically, it's identical to what the normal human pituitary gland makes. So pretty much you're just putting gas back in the gas tank. growth response to growth hormone, and the kids that have been on growth hormone has been what one would expect in a typical growth hormone deficient child. There are a bunch of frequently asked questions here, which I think I've given answers to. They're here for people to read through and to think through. They will be available to you. Probably better if, since I've already addressed the frequently asked questions, to let people chime in with their less frequently asked questions and try to address those while I'm online.
Thank you so much, Dr. Hale. And if you're comfortable with it, we'd be happy to share your slides on the website for World Chromosome 18 Day if people would like to look through these frequently asked questions. And we do have a question from Talia. Are there any cases in chromosome 18 conditions with endometriosis?
I'm aware of a couple of, for people who don't know, endometriosis is where basically the lining of the uterus has gotten out into the abdominal cavity, and blood inside of the abdominal cavity is quite irritating and cause considerable abdominal pain and discomfort. I'm aware of a few cases of endometriosis in in 18Q and 18P. We do not have a sufficient number of patients to say if it's a more common or less common than it is in the general population.
Great, thank you, Talia, and thank you, Dr. Hale. And we probably have time for one or two more questions if anyone would like to type their questions into the chat. In the meantime, we do have some questions prepared that we've received from families, throughout the year. One of the questions on your presentation, do we know why thyroid disorders are more common in those with chromosome 18 abnormalities?
That's sort of the million-dollar question. The bigger question is, why is it more common in all of the major chromosomal abnormalities? It's not just in the 18Q and 18P, et cetera. It's also in Turner's, it's in Down's. No, nobody has a hint or a clue. As a general rule, the process of making thyroid hormone is a complex process, and the immune system that leads to primary hypothyroidism or Hashimoto's thyroiditis is a very complex system. And I think the more complex the system, more likely something is to go haywire. But no, nobody knows.
Okay, well, good question then.
Yeah, well, actually, it's one of my little fantasies when I retire. We were talking earlier about people being able to do things they want to do.
Yeah.
That's one of the questions I would really like to pursue with people that are a lot smarter than I am on the autoimmune side of things, to figure out what there is special that makes all the chromosomal abnormalities at higher risk for developing Hashimoto's.
That's so interesting. So if you had unlimited funding, that's what you would pursue, or in retirement, that's what you'd like to pursue.
Right.
Related to Hashimoto's, what age do you typically see Hashimoto's onset in chromosome 18 individuals? Is there a typical age?
Well, so it seems that the children that last time we looked at, it's been a while, last time we looked at it, a relatively high percentage had the onset under the age of 5.
Wow.
Which is why we recommended screening, because, the 4-year-old that's constipated, you kind of don't automatically think, oh gosh, this is hypothyroidism. That's certainly not the track that the pediatricians go down, but it's why the Down Syndrome Society a number of years ago put out recommendations for screening kids with Downs, because the symptoms, particularly in younger children, can be confused with much more common things.
And is there a different age of onset that you typically see between men and women?
So there is not a huge difference. Now I cannot speak specifically to the chromosome 18 abnormalities. In the general population, Hashimoto's is considered an autoimmune process, and for most autoimmune conditions, although they are quite uncommon prior to the onset of puberty, there are not age differences in the onset in individuals prior to the onset of puberty. However, with the onset of puberty, all of the autoimmune conditions are about 10 times more common in women than in men. So pre-puberty, not much difference, and not much difference in prevalence or age at onset, but beyond puberty, much more common in women and more likely to have onset earlier.
That makes a lot of sense. Thank you. I haven't seen any other questions pop up in the chat. And I know we're a little bit over time, so we do have our next presentation in about 10 minutes. So
Okay.
is there anything else you'd like to cover before we take a break? And Dr. Karkar will be up next.
Not that I have.
Great. Well, thank you so much, Dr. Hale. I found your presentation really enlightening and I learned so much. And thank you everyone for your questions. So next up, we have a 10-minute break, and then at 5:45 Central Time, we will have Dr. Karkar come on.